Welcome back. It is my pleasure and honor to introduce Professor Ahmed Kurea, Professor of Internal Medicine and Nephrology, Alex University, and he is a well-known figure, and he is one of the active members within the Egyptian Society of Nephrology and Transplantation Board, and he shared in the establishment of the guidelines in GN and many guidelines from the Society of Nephrology. Today he will speak about the diet in CKD and acute kidney injury. Professor Kurea.
بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدا عبد الله ورسوله. It's always pleasure to be again in NephroShams, this time virtually, but hopefully we'll meet physically soon, inshallah. And of course, I have to extend my gratitude to Professor Magdi Shab and the team of Ain Shams Nephrology Unit for the great conference that's anticipated to take place as usual with the advancement in nephrology fields, in particularly hemodialysis and CKD. Professor Magdi, this time he assigned me to a rather tough subject, which is how diet management in AKI differs from CKD patient, which actually should entail both lectures all together. I hope to make it as much simple as I can and to manage to finish this impossible job in the 20 minutes assigned. First, we have to understand what we need to know about the patient with AKI regarding his nutritional status and support. We need to know about the metabolic and nutritional changes that occurs during acute kidney injury and how to evaluate the nutritional status of the patient in such a disease, and what are the principles of nutritional management for a patient with AKI, what are the different routes for providing the nutritional support and which is the preferred one, and the nutrition requirements and what are they specifically should be regarding both macro and micro nutrients. Just to simplify things and understanding how hypercatabolism is taking an upper hand, and this is actually the golden word in the field of AKI, because you know the normalized protein catabolic rate, the hypercatabolic state, the protein energy wasting, and the energy expenditure, and the basal metabolic rate all depend upon the hypercatabolic state that occurs. Just to understand why hypercatabolism is there, you need to look about both the critical illness that occurs in those patients and the AKI in conjunction. And both will lead to liver, kidney, muscle, and adipose tissue derangement, with the derangement in the metabolic pathways that is governed by these organs. For example, in the kidney failure, you have decrease in the gluconeogenesis and increase in the glutamine utilization. And this is a secret point where you are not allowed to give glutamine for patients in severe critical illness, especially when they develop multi-organ failure or AKI, and should be aware about any fluid that contains glutamine to be abandoned from usage. On the other hand, the liver, there is increase in the gluconeogenesis from amino acid, lactate, and glycerol, and hence you would have a negative nitrogen balance because of the gluconeogenesis from this part, and glycogenolysis will increase as well as glycolysis. And there is decrease in insulin-dependent glucose uptake, so the net result would be some sort of hyperglycemia with the deleterious effect to the kidney. Regarding the muscle, there would be decreased protein synthesis and increased protein breakdown. This will lead to branched chain amino acid oxidation and decreased intracellular glutamine level again. And as you can see, all these are negative catabolic factors leading to hypercatabolism. as well as in the adipose tissue, the decreasing in the insulin-dependent glucose uptake, the increasing in the glycolysis, and in the lactate, all lead to the lactic acidemia that occurs and the hyperglycemia as well. So the protein energy wasting, now being understood why it occurs, is the issue of AKI nutritional abnormality. And to diagnose protein energy wasting, you have a wasting of the lean body mass and the fat mass depletion in those patients with AKI. From those potential tools that are in development, like the body mass composition, the total body nitrogen, the energy beam-based methods with the bioimpedance analysis, CT and MR and others, still they are lacking data specifically in the AKI situation. Some of these might be validated in the chronic kidney disease patient and those on dialysis, but not on the AKI situation. On the other hand, the basic tools like subjective global assessment and its modification, or the protein catabolic rate, or the normalized nitrogen protein appearance, protein nitrogen appearance can be used. The muscle wasting by the anthropometry, as we measured earlier, the body waste and the lymphocytic count, the albumin, pre-albumin, and others, all can be used due to as a clinical method to determine the protein energy wasting in those patients with AKI. Again, both critical illness and acute kidney injury will lead through the multitude of these concomitant factors: the anorexia, gut dysfunction, the insulin resistance, the inflammation and catabolism, fluid retention due to poor urine output, the retention of uremic toxin due to the uremia and azotemia, the nutrient losses during renal replacement therapy, whether the intermittent or the chronic CRRT modality, and the muscle atrophy from immobility. All these leads to the protein energy wasting. So it's again a continuum from acute kidney injury and the critical illness altogether. How to measure energy expenditure? We have the indirect calorimetry, which unfortunately only applicable for those on ventilator with CO2 measurement, because you have to measure the oxygen consumption and the CO2 production. So you need a CO2 measuring ventilator or a capnogram in a monitor, and you should calculate the total amount of energy produced from the subtracting the CO2 production from the oxygen consumption. On the other hand, you can use the basal metabolic rate formula of Harris and Benedict, using both the body weight and height, and taking in consideration the age. Of course, it differs between males and females, and then you can calculate, which is not again so much accurate. And the estimation is based on the body water and on a 25 kilocalorie per kilogram. This is the recommendation of the European Society of Parenteral and Enteral Nutrition on the clinical nutrition guidelines for intensive care units. In critically ill, mechanically ventilated patient, energy expenditure should be determined using indirect calorimetry, and this is a great recommendation B with a strong consensus. It's a new tool that looks more promising, less invasive, and easily done, which is just bedside ultrasound measurement of the quadriceps muscle thickness. Widely available, inexpensive, non-invasive, independent of acute body weight changes due to fluid removal, whether the patient puts on fluid due to anuria or remove fluids due to ultrafiltration on dialysis and so on. And this has been validated just in a very recent trial a few days ago. They studied the quadriceps muscle thickness by the ultrasound and validate this by the gold standard, which is the CT scan of the muscle. and they found they are totally in agreement. And this is the paper just published a few days ago in the Journal of Nephrology. So indirect calorimetry is often not available, and energy expenditure is difficult to predict, and the equations failed in 80% of patients with risk of overfeeding or underfeeding in some patients. And so there is no single tool that's sensitive or specific enough in AKI, and maybe we should resort to the muscle thickness of the quadriceps as measured by the ultrasound till other tool would be available. Let's look for the principles of nutritional management in a patient with AKI and how this should go. The main goal of nutritional support in those patients should be to provide exogenous fuels and counteract the catabolic state that occurs in those critically ill patients, hence preventing the protein energy wasting, and this will lead to attenuation of the inflammatory state and improved said. This recent observation showed that in a patient with CKD stage 4 and 5, the protein restriction to a low protein diet around gram, this would adapt the muscle protein metabolism and decrease the progression. If you go further low to supplemented very low protein diet, going to 0.4 gram per kilogram supplemented by amino acid or keto acid of 0.1 gram per kilogram, this will lead to further decreasing in the muscle protein degradation and increasing the efficiency of muscle protein turnover with further protection of the kidney against CKD progression. Just to highlight this, a paper that is published in the JASN 4 years ago showed again that the keto analog supplemented with a vegetarian, very low protein diet decreases both CKD progression and the need for renal replacement therapy by up to 20 and 30%. Those patients with keto analog diet with 0.3 gram per kilogram vegetable protein, mainly of a vegetable only, with 1 capsule to every 5 kilogram. And this is an important issue. You should give the full dose. The patient weighing 80 kilos should receive 16 tablets of the keto analog, which is a high burden of tablet pills, but this is the way it goes. Versus patient not on regular protein, but on low protein diet of a lacto-ovo origin, which is again a very good choice. And in spite of this, there is difference of 30% endpoint, which is the initiation of renal replacement therapy, or a 50% decrease in the initial GFR, and 20% decrease in the renal replacement therapy initiation over a period of 1 year. So this is a real achievement. These are the factors affecting the level of protein restriction, the degree of renal sufficiency, of course, the nutritional status of the patient, the comorbid states, and the renal replacement therapy modality. And the recommended intake to the patient would be around 0.6 gram per kilogram if not on dialysis. If on hemodialysis, you should rise to 1.2 to 1.4 gram per kilogram. And again, just few days, the paper published in Journal American Society of Nephrology for the modifiable lifestyle factor for the primary prevention of CKD. And this is a systematic review of 104 studies with a meta-analysis for more than 2 million and 3/4 patients or participants. And look for the results. This is regarding vegetables. The higher the vegetable intake, the more protected you are against CKD. And these are the number of studies that have been studying this issue. And this is potassium against all odds. The higher potassium intake, the more you are protected against CKD. So don't restrict potassium except for those patients who are at risk of hyperkalemia, and manage it very wisely. Of course, as expected, the sodium, the higher sodium intake, the more you are at risk for progression or occurrence of CKD. And these were the reduced odds of CKD, higher vegetable intake and potassium intake, increased odds for higher sodium intake. And significant reduced odds of incident CKD for those people with increased physical activity. And these are other factors like tobacco smoking, like albuminuria and physical, but please look here for protein restriction in 5 studies and the participant of 18,000, and the level of evidence is low. And there is just the odds ratio of 1.07, not too much, but if you use a vegetarian diet, the higher vegetable, the more protective you are. And these are the example for the vegetables, the potassium, the physical activity, the alcohol consumption, the sodium, and the tobacco smoking, and the value for each one of these, how much it would help regarding the GFR decline and the occurrence of albuminuria, and the protection against renal replacement therapy. I think for the sake of time, I would like to stop here, and I hope that I've alluded some of the integral differences between the AKI and the CKD regarding their management from an MTN initiative or a medical therapeutic nutrition initiative. And I would like to highlight the role of a clinical nutritionist hand in hand with the nephrologist and the intensivist in preparing the diet for both patients with AKI and CKD. They are really indispensable nowadays in our modern practice. Thanks for your attention, and hope to see you soon on a physical background, and I'll be glad to receive any questions if any.
It's my pleasure and honor to introduce my dear colleague, Professor Iman Sarhan. She is a professor of internal medicine and nephrology in Ain Shams University, and she will talk about the understanding sources of the erythropoietin phosphorus in patients with chronic kidney disease. Professor Iman.
بيسعدني ان انا اكون موجوده في المؤتمر السنه دي، بالرغم ان هو مختلف شويه عن المؤتمرات اللي قبل كده. يمكن احنا السنه دي تعودنا على الفيرتشوال ميتنج، ان شاء الله باذن الله يكون الكوميونيكيشن افضل. الموضوع بتاعنا النهارده هو على understanding the source of dietary phosphorus in treatment of patient with chronic kidney disease. حقيقي chronic kidney disease patient, as we know, we have 5 stages of chronic kidney disease. We just see the tip of iceberg اللي هو stage 5, لكن we have the stage 3 and 4, and this considered as overt because they have some symptoms for chronic kidney disease, and stage 1 and 2 usually it's covered or it is not manifested as they have no symptom. And we know we need to calculate the estimated GFR to reach to the stages of chronic kidney disease, which help us for all management later on. The calculation, there is some equations, and we know that Cockcroft Gold formula, which is the easiest, we used it before, but it's overestimate the GFR. So after the MDRD study, and MDRD study also underestimate the GFR, and finally they approved or they prefer, the National Kidney Foundation prefer CKD EBI calculation, and this can be get it easily through mobile application. We go to our topic, which is about the phosphorus. Phosphorus play a critical role in many biological processes, including energy, metabolism, cellular signaling, through phosphorylation of protein, nucleic acid metabolism, membrane integrity, and bone mineralization. Actually, we have 600 to 800 gram total phosphorus in the body. Bone found about 85% bounded for bone, intracellular about 14%, and we have extracellular only 1%. Normal level of phosphorus between 2.5 to 4 milligram per day per percent. Extracellular phosphorus, which is a 1%, can be also divided into 70% organic phospholipid present as a phospholipid and 30% inorganic. Inorganic, 85% free in circulation, but it complexed with sodium, magnesium, calcium, or may be found ionized, and 15% is protein bound. This is the phosphorus homeostasis. We have already taken about 20 milligram per kg per day phosphorus from the food, and this go to the intestine. Absorption about 16 milligram per kg, and go to the phosphorus pool in the body. And as we see before, the phosphorus pool, some of this phosphorus will be returned back to GI through digestive juice phosphorus, about 3 milligram. So now we have remnant here 4 milligram, and also 3 coming in digestive food. So the feces excrete about 7 milligram per kg phosphorus per day. The other, about 13 milligram, will be secreted through the urine, excreted from urine. And 3 milligram will go as homeostasis through the bone by bone formation and bone resorption. This is the turnover of the bone. In chronic kidney disease, we have phosphate retention. This is the most important step, which this is come from the decrease the phosphorus excretions from the kidney. And this will make both the phosphorus balance. This will increase the phosphorus, so it will increase the FGF23. And this FGF23 go to the kidney line or trying to increase the excretion of phosphorus from the urine, so it will help to correct the hyperphosphatemia present. At the same time, it decreases the 125 hydroxycholecalciferol. This is active form of vitamin D, so it will decrease the calcium absorption from the gut, and this will increase the parathyroid hormone, helping to, at the same time, increase secretions of phosphorus from to the urine, and on the other side, it will result in secondary hyperparathyroidism. Actually, this is increase FGF and decrease 1-alpha or 1,25 hydroxycholecalciferol will trying to increase the urine excretion of phosphorus, trying to correct the problem. So this is the two problem occur, or the main player in CKD patient as regards phosphate metabolism. Then we have target, nutritional target. Usually if we have CKD patient for stage 1 and 2, there is no requirement for any nutritional restriction. But from 3 to 5 non-dialysis, so in conservative, we need to restrict the protein. Protein restricted to 0.8 gram per kg, about 60% of them from animal source and 40% will be from plant source. We are not recommending to prescribe less than 0.6 gram per kg per day. We need diet rich in vegetable, less in sodium, potassium not restricted except if the serum level is high, calcium between 1,000 to 1,500 milligram per day. And this we come to the phosphorus. Phosphorus need to be restricted to 0.8 to 1 gram per day, even if the phosphorus is normal. So this is important because potassium restriction occur only when the hyperkalemia or when the potassium is high, but phosphorus restriction must be done early in stage 3, even normal phosphorus. This is prevent the occurrence of increase FGF23 and decrease the calcium and secondary hyperparathyroidism. Requirement بتاع الفوسفورس is 0.8 to 1 gram, even if the serum phosphorus is normal, and this is important. I just make it sure that phosphorus restriction occur even the serum phosphorus is normal, starting from stage 3, and the phosphorus restriction trying to maintain the normal level. How to calculate for this, or calculate for this 0.8 or 800 milligram phosphorus, 1,000 milligram phosphorus? We need, first, we know that the phosphorus is linked to the protein. So we need to make it protein calculation first. So I will calculate the 0.8 gram per kg per day protein, and I need 60% of high biological value. And I need to know that 1 ounce, this is the serving by nutrition, دي بيقولوا عليها حصة. الحصة تساوي 1 over 8 cup، يعني 8 كوباية، يعني 28 جرام، يعني معلقتين كبار من معالق الشوربة. يبقى إذا دي هي اللي بنقول عليها لما يقول له خد 1 serving، يبقى بتبقى غالبا 1 ounce لو ما ذكرش حاجة تانية. ال3.5 ounce بيعتبروا 100 جرام، 100 جرام. تعالوا نشوف الكلام ده ممكن يترجم ازاي للعيانين. لو انا خدت الهاند فيست كامله دي بتبقى 1 كاب، يعني ال1 كاب حوالي 200 جرام. لو خدت الصمب بس يبقى 30 جرام، يعني تقريبا 1 ounce. يبقى اذا دي مهمه جدا، عشان انا دايما التشيز بناخدها 1 ounce، تبقى تتاخد بالظبط قد الصمب بالنسبه لنا. البالم this is the palm. The palm is about 3 ounce، about تقريبا حوالي 100 جرام. ده تقريبا المقاس بتاعي بتاع اللحمه والفراخ والسمك. لو انا عايزه اخد 1 تي سبون ممكن اخد التيب فينجر. لو عايزه اخد 1 تيبل سبون ممكن اخد السامب فينجر يديني ال 15. هنا بزود كميه البروتينات. طب احنا عارفين ان معظم الفوسفورس موجود مينلي في البروتين، وبالتالي هيبقى عندي فيه مشكله ان كده الفوسفورس كونتنت بتاعه هيزيد وهيعدي ال 1000 مللي جرام اللي احنا متفقين عليه. طيب يبقى انا كده غالبا هاكسيدنج ال 1000 مللي جرام لو انا زودت البروتين في العيان اللي على هيموداياليسيس. الحل هيبقى ايه؟ خلينا نحسبها كده. لو حسبناها ان في العيانين اللي هم بياخدوا الفود، لو بياخد 1000 مللي جرام يبقى حوالي بياخد 7000 مللي جرام في الاسبوع، 60% منهم ابزوربت، حسبها ان هي 4300. هيتحط على الدياليسيس 3 مرات في الاسبوع، هيشيل منهم تقريبا حوالي 800 في كل جلسه، يبقى يشيل 2400. هنا يبقى ستيل عندي في بص فوسفورس بالانس ب 1800. الحل هيبقى ايه؟ الحل بالنسبه لي ان انا هيبقى عندي لو قسمتهم على السبعه دول محتاجه 257 مللي جرام، دول اكسس، دول انا هستعوضهم بالفوسفيت بايندر. يبقى انا اذا الفوسفيت بايندر هتبقى مهمه جدا بالنسبه للعيانين، خصوصا اللي على الهيمودياليسيس، لان دي غالبا انا بحاول ارفع الفوسفات، بحاول ارفع البروتين، ومع رفع البروتين بيزيد الفوسفورس، فانا ببقى بالتالي محتاجه ان انا اقلل امتصاص الفوسفورس عن طريق الفوسفيت بايندر. طبعا لو انا بتكلم على HDF ده ممكن يفرق بالنسبه للريموفال بتاع الفوسفورس عن الهيمودياليسيس العادي. طيب الكلام طبعا حته ان الفوسفيت بايندر بيفرق. طبعا الفوسفيت بايندر لان هو بيفرق بالنسبه للعيانين في السرفايفل. يعني هنا السرفايفل للناس اللي على الفوسفيت بايندر افضل من الناس اللي هي مش على الفوسفيت بايندر ايفن النون دايلسيس، ودي بتبقى من الحاجات اللي هتبقى مهمه بالنسبه لنا. طب هل احنا زي ما انا كنت بقول لكم ممكن اعمل بروتين ريستريكشن علشان اوصل الفوسفورس كونتنت بتاع العيان دون ل 1000 مللي جرام؟ لقوا ان هم لما لقوا احسن سرفايفل دي، احسن سرفايفل دي اللي هي اقل من 1 دي، لقوهم مين؟ الناس اللي عندهم البروتين انتاج انكريز والفوسفورس ديكريز. البروتين انتاج انكريز والفوسفورس ديكريز، يعني معنى كده ان انا ما امنعش الانتاج بتاع البروتين، هديله الريكويرمنت بتاعته اللي هي 1/10 جرام بير كي جي بير داي، وهحاول ان انا اشيل الحاجات اللي هي الانسيسري فوسفورس اللي هي زي ما اتفقنا الحاجات اللي في الفود اديشن. والحاجه الثانيه ان انا احاول استخدم الفوسفيت بايندر عشان يبقى الفوسفور قليل، ودول بيبقوا افضل سرفايفل على الدايلس. طيب لو احنا زودنا زي ما هنا كده، زودنا الفوسفورس وزودنا البروتين انتيك، هنلاقي بدا يبقى السرفايفل اقل. طب لو قللنا البروتين والفوسفورس عالي، السرفايفل اعلى حاجه، المورتاليتي اعلى حاجه، السرفايفل هتبقى اقل. لو البروتين انتيك والفوسفورس انتيك برضو الاثنين لقوا ان برضو المورتاليتي بتزيد. يبقى اذا تاني هقول افضل عيان هو اللي هياخد جود بروتين انتيك ويبقى عنده لو فوسفورس. يبقى انا هحتاج اني اختار البروتين اللي هو اوف لو فوسفورس تو بروتين ريشيو، دي حاجه. الحاجه الثانيه اني ما امنعش العيان من الامبورتنت بروتين بالنسبه له، ان انا استخدم الفوسفيت بايندر، ولو العيان على دايلسيس هبقى محتاجه اعمل اظبط الدايلسيس بالنسبه له. ازاي ان احنا نقلل حقيقي الفوسفيت من الاكل؟ من ضمن الحاجات اللي احنا بنقولها ان احنا زي ما اتفقنا ان احنا بنافويد الحاجات اللي هي جايه من النص. طبعا النص لو هياخد كميه قليله. التشيز مهمه، اليوك هنحاول نقلله. بعض البليتري والفيش بعضهم مش كلهم، بنحاول ان احنا ناخد الحاجات اللي هي بروتين تو فوسفورس عالي، احاول اخليها تبقى السيرفنج بتاعتها انفريكوينت، واخلي الحاجات اللي هي عندنا بروتين تو فوسفورس قليل اخلي الفريكونسي بتاعتها تبقى ديلي. ان استخدم البلانت اوريجين بروتين لان الانسان ابزوربشن بتاعته بتبقى قليله. هافويد كل الحاجات اللي فيها فوسفورس اديشن، مهم جدا. اي حاجه فيها فوسفوريك اسيد غالبا اللي هي كلها بتبقى ادد للسوفت درينك، كل ده بيبقى ماست بي افويد. اقلل الفوسفورس ثاني ازاي؟ نعمل ايه؟ بويلنج. البويلنج بيقلل لي 51% من الفوسفورس في الفيجيتابل، 48% من الفوسفورس اللي في الليجن، 38% من الفوسفورس اللي في الميت. يهمني بقى ان انا العيان ما يشربش الشوربه بعد كده لان غالبا هيبقى فيها الفوسفورس اللي نزل. فده احنا بنعمل حاجه اسمها مينراليزيشن بتاع الفود، وده بيقلل شويه الفوسفورس والبوتاسيوم والكالسيوم. يعني دي واي ان انا اقلل اكتر حاجه موجوده بالنسبه لنا يبقى dangerous. الحاجه الثانيه identify and avoid the phosphate addition which is very important. طيب انا وصلت لاخر نقطه في المحاضره، الحاجات التبس اللي احنا عايزين نوصل لها بعد المحاضره دي، ان احنا بنحاول ان احنا نبدا ريستريكشن للفوسفورس في chronic kidney disease stage 3 ل 5 including الهيمو dialysis والبريتونيال dialysis لو كان even السيرم فوسفورس is normal. الريستريكشن بتاع الفوسفورس هيبقى من 800 ل 1000 مللي جرام بر داي. فوسفورس لينكد للبروتين وبالتالي بروتين ريستريكشن هيهلب معايا ان انا اعمل فوسفورس ريستريكشن. البروتين ريستريكشن بيبقى 8 من 10 في كل السي كي دي نون داياليسيس وبيبقى 1.2 من 10 جرام للعيانين السي كي دي على الداياليسيس، 1.3 من 10 جرام بر كي جي على للعيانين اللي هم على بريتونيال داياليسيس. دايما نختار هنقول انيمال والبلانت بروتين، حوالي 60% يبقى انيمال و40% بلانت اوريجين بروتين لانه عنده فوسفورس لو فوسفورس بايو افيلابيليتي. دايما نختار الانيمال بروتين اوف لو فوسفورس كونتنت اللي هو البروتين للفوسفورس بروتين ريشيو اقل من 12 مللي جرام بر جرام بروتين، والحاجات اللي هي هاي بروتين لفوسفورس ريشيو اخلي ان انا تبقى ليس فريكوينت، يعني ما ياخدهاش كل يوم، ياخدها مره في الاسبوع. دونت ريستريكت بروتين الهيمودايلس بروتينيال دايلس، مهم جدا. انا هدي البروتين اللي هو الاود بالنسبه للعيانين دول، ولو انا عندي الفوسفورس عالي انا هافويد الانسيسري فوسفورس، دي مهم جدا. هستخدم الفوسفيت بايندر، هحاول استخدم مور افيشنت دايلسيس، وطبعا لو حبذا الاتش دي اف من ضمن الحاجات اللي هي بتساعد في الفوسفورس. دايما نخلي بالنا افويد كل الفوسفورس اديتيف، كل الحاجه اللي هي بنقول عليها processed meat, processed cheese, and processed chicken. This is a very important, and this is my tips for you and for your patient today. Thank you.
دلوقتي معلش انا بعلق على المحاضره اللي فاتت، واحنا لسه فيها جزء حقيقي على السورس بتاع الدايتوري دايت فوسفورس، وبالتالي هنتكلم عن الفوسفورس بيراميد. يمكن هتتقال عشان وقت بس المؤتمر، هتتقال في اخر البروجرام النهارده. دلوقتي يسعدني ويشرفني I have my pleasure to introduce our professor Dr. محمد صبح. Dr. محمد صبح is a well-known figure in nephrology. And he is a professor of internal medicine and nephrology in Mansoura University. He's talk about zinc in CKD and hemodialysis. Professor صبح.
is an important scientific problem. election. The duration and severity of common cold in healthy people when taken within 24 hours of onset of symptoms. So, common cold. Wound healing. Zinc help maintain the integrity of skin and mucosal membrane. Patients with chronic leg ulcer have abnormal zinc metabolism and low serum zinc level, and clinicians frequently treat zinc ulcer, skin ulcer with zinc supplement. Another more serious problem, which is age-related macular degeneration. Researchers have suggested that both zinc and antioxidants delay the progression of age-related macular degeneration and vision loss, possibly by preventing cellular damage in the retina. In a population-based cohort study in Netherlands, high dietary intake of zinc, as well as beta-carotene, vitamin C, and vitamin E was associated with a reduced risk of age-mediated macular degeneration in elderly subjects. Zinc deficiency. Zinc deficiency is characterized by gross retardation, loss of appetite, and impaired immune function. In more severe cases, zinc deficiency causes hair loss, diarrhea, delayed sexual maturation, impotence, hypogonadism in male, and eye and skin lesions, weight loss, delayed healing of wound, taste abnormalities, and mental lethargy can also occur. We see from these symptoms, many of which are non-specific and often associated with other health conditions. So as a clinician, we have to expect both zinc in the differential diagnosis when we need this condition, since management will be easy, just giving zinc supplementation. How can we assess our body zinc? What's available is plasma serum zinc level. This is available, and despite it is not ideal, since as we know, most of our zinc is not in serum or plasma, but it is in the muscle and bone. But it is available one and applicable as well. And also clinician, since zinc deficiency can occur with normal plasma serum zinc, so it should be considered. And we can add zinc when we are in doubt. Are there a group of people who are more susceptible to zinc inadequacy? Yes. People with gastrointestinal problems such as gastrointestinal surgery, digestive disorders such as ulcerative colitis, Crohn's disease, short bowel disease, all these people are liable to zinc, hypozincemia. Other disease as well, such as malabsorption syndrome, chronic diarrhea, chronic liver disease, chronic renal disease, sickle cell disease, diabetes, malignancy, and other chronic illness, all can be associated with zinc deficiency. Veterinarians are liable to zinc deficiency, since we know zinc is more in meat and fish and so on. And aside, in addition, vegetarians usually eat much medium whole grain and whole grains, which contain phytates that bind zinc and inhibit its absorption. So vegetarian, also pregnant and lactating women are liable to hypozincemia. Infant, older infant, or whom are exclusively dependent on breastfeed can be subjected to zinc, low zinc level. People with sickle cell disease are liable to have low level of zinc as well. And alcoholic, nearly 30 to 50% of alcoholics have low zinc status because ethanol consumption decreases intestinal absorption of zinc and also increase urinary zinc excretion. What is the relation between zinc and iron and copper? We know when we give iron to support food, it can inhibit zinc absorption. We have to be aware of this. So we can give iron in between meals. Okay. Also, if you give zinc in high amount, it can prevent or suppress copper absorption. And to manifest as cover insufficiency. Also, not only low zinc level is associated with a lot of problems, but also if the patient is subjected to toxic dose of zinc, it has a lot of problem as well, including vomiting, nausea, vomiting, loss of appetite, abdominal cramps, diarrhea, and headache. Level like this can cause a lot of complications. So also over a higher level of zinc can cause problem. Now I'm going to zinc and kidney, our target of today's lecture. This is a very interesting publication which has been published last year, talking about renal handling of zinc in chronic kidney disease patients and the role of circulating zinc level in renal function decline. So, in this paper, the aims of the study were to assess whether zinc deficiency was related to increased renal excretion of zinc. Hypozincemia is it due to hyperzincuria? This is the target number one. And two, if there is a relationship between zinc deficiency and progression of CKD. What they did, they used 108 patients with CKD, and they used 81 persons as control, healthy control. And they measured plasma 24-hour urine zinc excretion, and of course serum and plasma excretion, urine electrolyte, and they used uromodulin as a marker of integrity of the tubule. Also, serum creatinine was measured regularly over 3 years to calculate the yearly change in estimated GFR. Multivariate regression analysis was performed to assess the association between baseline zinc at the beginning and the yearly change in GFR. What they found, CKD patients had lower circulating level of zinc, so low zinc level in blood, and higher 24-hour urine excretion, so hypozincemia and hyperzincuria, than in healthy control. Number one, fractional excretion of zinc was higher in uremic than normal control, and significantly increased at more advanced CKD. When the kidney function is deteriorating, serum urinary zinc is going down, is increasing, and blood zinc is going down. Zinc fractional excretion was correlated negatively with 24-hour urinary uromodulin excretion, i.e., the less integrity of tubule, the more the zinc loss in urine. What more? Lower baseline plasma zinc level were associated with a faster yearly decline in the renal function. So these are very important information. When you have low zinc, this will be due to high zinc loss in urine, and this low zinc say that this kidney will deteriorate more rapidly. So possibly correction of low zinc can sustain good kidney function. This is the first publication. Another interesting publication is the story of zinc and vascular calcification. This paper has published just last year, also a recent one. Study association between dietary zinc intake and abdominal aortic calcification in healthy adult, not CKD, but what apply in healthy adult mostly apply in uremic as well, and as we are going to see now. Background. It has been reported before that in animal studies, zinc supplementation inhibited phosphate-induced arterial calcification. Good. So the author tested the hypothesis that higher intake of zinc was associated with lower abdominal aortic calcification, among other in the United States. This is the hypothesis. What they did? They performed a cross-sectional analysis of 2,535 participants from National Health and Nutritional Examination Survey. Dietary and supplemental zinc intake were evaluated, and also by DEXA X-ray examination, they calculated amount of calcium calcification in the aorta, and they divided their patient into 3 groups. Group 1, in which there was no calcification for aorta. Group 2, mild to moderate aortic calcification. And group 3, in which there was severe aortic calcification. Okay, what they found? Interesting. Higher intake of zinc, dietary zinc, was associated with lower odds of having severe abdominal aortic calcification. They calculated this and found that 1 milligram daily higher intake of zinc, the odds of having severe abdominal aortic calcification were 8% lower. So calculated risk. So they concluded higher intake of dietary zinc was independently associated with lower odds of having severe abdominal aortic calcification among non-institutional healthy adults, and 10 months respectively. So zinc decreased the dose and decreased the resistance to erythropoietin in this patient. Change in serum zinc level was an independent predictor of lowered erythropoietin resistance index. They concluded that zinc supplementation reduced erythropoietin resistance index in patients undergoing hemodialysis and may be a novel therapeutic strategy for patients with renal anemia and low serum zinc level. Good point. And these are the 2 groups. This is the erythropoietin resistance index, and this is the time. You see, in group treated by zinc, the resistive index decreased, and consequently, the dose of erythropoietin was decreased. And this is the change in the resistive index, a change in zinc concentration. They found a linear relationship between both. So, Mr. Chairman and dear colleague, now I'm coming to conclusion. I'd like to say that zinc is essential for life. It plays a role in immune function, protein synthesis, wound healing, DNA synthesis, and cell division. One may become zinc deficient via several different ways, including not consuming enough zinc in diet, decreasing zinc absorption due to diarrhea and or gastrointestinal condition, excess zinc being lost during dialysis, use of corticosteroids, use of diuretic. All these can cause zinc. And actually, in our real life, in our clinical practice, we are confronted with patients having these conditions, so we have to remember zinc. Signs of zinc deficiency may include lack of energy, hair loss, loss of appetite, redness, flaking, scaling of the nasal region, weight loss, slow wound healing, decreased ability to taste food, particularly sweet, sour, bitter, and salty food, reduced ability to smell and picker. Zinc deficiency is common among dialysis patients. It is estimated to affect 40 to 78% of dialysis patients. So our patients are zinc deficient. Decrease body zinc may increase CKD progression. Very serious. We have to consider it. Zinc supplementation may be beneficial for nutritional status in children and adolescents. Don't forget, zinc deficiency causes anemia in CKD and hemodialysis patients. Its supplementation promotes the action of erythropoietin. Low body zinc increase vascular calcification in normal and in CKD individual. The another, as we know, the cause number one in mortality in our patient is vascular calcification. So zinc variation can help us to rescue these patients. High zinc intake decreases abdominal aortic calcification. This risky health risk problem in uremic and healthy persons. So look to zinc, please. And finally, and interestingly, zinc inhibit heme stabilizer induced vascular calcification. And thank you.
It's my pleasure for me to introduce Professor Dr. Ali Saw, Head of Nephrology Division in Jahra Hospital in Kuwait and past President in Nephrology Association in Kuwait also. He will talk about update of phosphorus control in end-stage kidney disease. تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizers for inviting me. It's truly an honor, and I would like to thank the audience for being here to join us. My colleagues have already talked about CKD and BD and the dietary sources of phosphorus, so I'll focus on how to control phosphorus in the advanced CKD end-stage kidney disease patient. We all know that high phosphorus is detrimental to health. It is an independent risk factor for accelerated mortality, CKD progression, and aging. It causes calcification, arterial stiffness, LVH, endothelial dysfunction, and insulin resistance. And as you see in the graphs below, there is increased calcification level in non-dialysis CKD patients with increasing phosphorus level. And the second one shows you that high phosphorus is actually more as a mortality risk factor than other complications of end-stage kidney disease like anemia, high calcium, or high PTH. The adverse outcomes are secondary to calcium phosphorus nanocrystal formation, but also to the adaptive responses, which are the high parathyroid hormone and high FGF23. The level at which phosphorus becomes significantly linked to mortality varies, and mortality increases by probably 0.6% for each 0.3 millimole increase in phosphorus above 1.8 in end-stage kidney disease. Even healthy people who have phosphorus in the top 25% of normal range are at increased risk of CKD and end-stage kidney disease cardiovascular events. And these graphs show you that the phosphorus level and mortality in non-CKD patients, phosphorus level and mortality in non-dialysis CKD patients, and phosphorus level and mortality in dialysis patients in observational studies from 2 large dialysis providers in the United States. So, what are the current phosphorus management recommendations? According to KDIGO, the therapy is based on serial measurements of phosphorus, calcium, PTH taken together. Aim for lowering elevated phosphorus levels toward normal range. You use phosphorus lowering strategy based on progressively or persistently high phosphorus and not a single reading. The early preventive therapy in patients on phosphorus is not supported by data. Limitation of phosphorus intake alone or in combination with other therapies to treat hyperphosphatemia, and consider the phosphorus source. Avoid hypercalcemia, use low dialysate calcium, and restrict calcium-based binders. The KDIGO guidelines published recently advising to adjust dietary phosphorus intake, again, to keep phosphorus normal. And if you are restricting dietary phosphorus, consider the bioavailability of the food source, and again, restrict elemental calcium from diet. Now, we all know that high phosphorus is now, but what about phosphorus lowering? Does correction of high phosphorus lower CKD and PD adverse clinical outcomes? There's actually a lack of long-term RCTs evidence on hard outcomes for both CKD and DL5D. The trials are designed for surrogate outcomes, phosphorus, FGF23, PTH, alkaline phosphatase, and not the true clinical outcomes. Systematic reviews and meta-analyses have produced conflicting conclusions. There is moderate to high bias risks due to open label, selective outcomes, incomplete outcome data, attrition, industry sponsorship, and small size. But in observational studies, there is survival benefit for phosphorus restriction and phosphorus binders. So let's start with dietary restriction. My colleague has already talked to you about the dietary sources of phosphorus, but just in brief, the animal protein, from which 40 to 60% absorbed, plant protein, from which 20 to 40% absorbed due to lack of, because it's in phytate form and the human gut lacks phytase. The most important currently is the processed food and food additives, in which 90% of the added inorganic phosphorus is absorbed passively by the paracellular route. And a neglected or forgotten source of dietary phosphorus is the medications. 10% of meds have phosphorus as buffer, diluent, or density. 30% of hemodialysis patients are on at least one phosphorus-containing medication. Examples are amlodipine, lisinopril, bisoprolol, rosuvastatin, glyburide, and sitagliptin. Absorption of phosphorus is also affected by vitamin D receptor activation and the presence or absence of binders or inhibitors. Boiling demineralizes vegetables and animal-derived food. It actually reduces phosphorus, calcium, sodium, potassium in proportion to the amount of water, the portion size, and the cooking time, without a significant impact on the protein or nitrogen intake. But the challenges with diet restriction are numerous. There's little information on to estimate the phosphorus amount contributed by additives. Difficult to fully distinguish between organic and additive-based inorganic phosphorus in foods that we eat daily. Difficult to assess dietary phosphorus intake due to outdated values in the food composition tables. The amount of phosphorus in foods is underrepresented in nutrition labels. It's absent in so many. And in the educational intervention studies, there is short-term studies in improving phosphorus, but however, unfortunately, there is no long-term evidence of long-term success. So the current literature suggests to restrict phosphorus intake to less than 1,000 milligrams per day under dietitian supervision to avoid malnutrition. Remember, restricting phosphorus means it has to go hand in hand with protein restriction. However, the KDOQ statement suggests that the efficacy of phosphorus intake reduction to less than 1,000 in CKD3 to 5D to keep phosphorus normal is not established and is higher than current Institute of Medicine recommended daily allowance of 700 milligrams. That was published in 1997 and has not been updated and has not been validated for CKD patients. Now, most natural dietary phosphorus comes from protein-containing foods. Globally, plant-based foods are the leading source of protein, 6% comprising 6% of daily intake. The rest is from meat, dairy, fish, and other animals. In Western countries, it's the opposite. 60% of daily phosphorus intake comes from meat, chicken, fish, egg, dairy, and wheat. And the two diagrams showing to you that the first on the left shows that the higher protein intake, the higher the phosphorus intake. The second diagram on the left shows that the higher protein intake, the higher the serum phosphorus level. So they go hand in hand. You restrict protein, have to restrict protein to restrict phosphorus intake. However, Kadioki statement suggests the evidence insufficient to recommend particular protein type, plant versus animal, regarding effects on nutritional status, calcium, phosphorus, or lipids in CKD125B. This brings me to talk about the plant-dominant low-protein diet that has been promoted recently and it's been pushed aggressively by some authorities. It's interesting to know about it. First of all, it's consumption of fruits, vegetables, nuts, seeds, oils, grains, legumes, and beans, with or without meat, fish, egg, and dairy products like the vegan diet, vegetarian diet, DASH, or Mediterranean diet. Of course, there are challenges and difficulties of this plant-dominant low-protein diet. You can have some deficiencies in important elements like heme iron, D3, DHA, B12. They have lower biological values of proteins and plant-based proteins than animals. Phytate in plant-based proteins may impair zinc and iron absorption. However, the risk of nutritional deficiencies can be lowered if the plant sources are diverse. But other problems include low palatability and poor adherence. It can hinder obesity control because protein has satiety effect. It can maintain lean body mass by increase energy use. It can cause high glycemic index because protein delays stomach emptying. When you don't have that much protein, then you can elevate the glycemic index. There's also a risk of hyperkalemia. As you know, some fruits, vegetables, bran are rich in potassium. But there are benefits of the plant-based low-protein diet. It can slow down CKD progression by synergistic effect with RAS and SGLT2 blockers in lowering intraglomerular pressure. There is a reduction of products that may worsen CKD. It can improve gut microbiome, higher intake of anti-inflammatory and antioxidant fiber intake, reduction in nitrogenous compounds, so it reduces ammonia and appetite-suppressing uremic toxins. This may help control uremia and delay dialysis initiation. Plant foods have lower acidogenicity than animal foods, which decreases acid load. And just briefly, let me show you these benefits. The first top graph shows you the low intraglomerular pressure produced by low sodium diet, low protein diet, SGLT2 inhibitors, and RAS blockers. The bottom left graph shows you how it improves the gut microbiome and reduces the absorption of inflammatory and uremic toxins. On the bottom graph on the right, it shows how it reduces acidogenicity. There's also less absorbable phosphorus in plant-based proteins since it is bound to indigestible phytate, although there are exceptions. High fiber intake also enhances the eye motility, lowering the odds of constipation, and that reduces the risk of hyperkalemia. Moving on to the next step in managing hyperphosphatemia, and that is using phosphorus-lowering agents. And I'm not saying phosphorus binders because, as you can see, not all of them are binders. The best are sucroferric oxide hydroxide and lanthanum. Now, tenapanor, although it has a very low number of pills, but it has not yet officially approved for hyperphosphatemia. The cost, most of them are expensive. Sevelamer here may appear cheaper than lanthanum, but the number of pills, if you increase the number of pills, then it will be more expensive. The cost, calcium binders much cheaper than non-calcium binders, and generics are cheaper than branded. Other issues in deciding, well, limited data in pregnancy for calcium acetate, lanthanum, and sevelamer. However, in pregnancy, we usually do more frequent dialysis, and that helps in controlling phosphate, probably reducing the need for binders. There's limited data and combination to lower doses to limit side effects and maximize bindings. Now, let's start with the calcium-based phosphorus binders. Calcium carbonate or calcium acetate. They have low affinity for phosphorus. And that means they're requiring larger doses and higher number of pills to control phosphorus. And that can increase calcium load, increasing vascular calcification and mortality. They're also non-palatable and can cause constipation. They can reduce iron absorption, and they are less effective, especially calcium carbonate, less effective if patient is on PPI or H2 blockers because they require the acid pH. And avoid, again, calcium citrate and any citrate-containing drug because it can increase GI absorption of aluminum. Now, KDIGO and KDOQI recommend restricting the use of calcium binders, and the current literature says that the total intake of calcium should not exceed 2 grams per day, the elemental calcium, which means that you have to restrict the number of pills per day to combat hyperphosphatemia. There's also the magnesium calcium combination binders. It is effective, tolerated, and may reduce pill burden compared to calcium acetate alone. And lowering calcium load may reduce cardiovascular calcification and cardiovascular events. And magnesium also may be protective. However, it's less potent than calcium. The pure calcium-based binders may cause hypermagnesemia, but if you reduce the magnesium back in the dialysis solution, then you may avoid this problem, and it can cause diarrhea. What about the non-calcium-based phosphorus binders? Well, sevelamer is the most famous one, and it's synthetic, non-absorbable bile acid sequestrant, cationic polymer, binds to negatively charged phosphorus urate oxalate via ion exchange. The pros: it's as effective as calcium-based binders in controlling phosphorus level. It delivers no calcium and increases FET1A, so less hypercalcemia and less calcification. So it may reduce coronary calcification, arrhythmia, and cardiovascular mortality, as it's shown in these graphs. But again, these are either observational or retrospective analysis, and as you can see, can cause reduce all-cause survival or cardiovascular survival. It can reduce coronary artery calcification, reduce hypercalcemia, but as you see in the table, the quality of evidence is not great. There's also the pleiotropic effects. It can improve lipid profile, lower uric acid, age and endotoxins, inflammatory markers, and insulin resistance, and may help correct acidosis with the sevelamer carbonate. Now, people are not using sevelamer hydrochloride. The cons: large pill burden due to low affinity. You may take 3 to 5 pills per meal, or 9 to 15 pills per day, and that's huge. It can bind Lasix, cyclosporin to columns, rendering them less effective, and may impair absorption of fat-soluble vitamins A, D, E, and K, and expensive. Lanthanum, on the other hand, is a rare earth element with very low bioavailability, which means very little is absorbed. It dissociates in acidic stomach milieu to release lanthanum ion over GI. It binds phosphorus independently of pH to form this insoluble lanthanum phosphate complex. So the pros: lanthanum binding affinity is similar to that of aluminum, which means great. It can reduces phosphorus absorption by 4 to 5%. Sevelamer and calcium acetate binding affinity is lower and declines significantly at low pH. It is stable in the presence of bile acid. Unlike sevelamer, it does not affect fat-soluble vitamins absorption, and citrate does not increase lanthanum absorption, unlike with aluminum. It is good in lowering phosphorus, stabilizing pH, and better than the sevelamer calcium carbonate in pill burden and pH resistance and lowering FGF23. Released slowly from bones after withdrawal without toxicity, and it's better than calcium carbonate in attenuating aortic calcification, and delays coronary artery calcification progression compared to calcium. The cons: well, of course, the GI effect is chewable, so may not be suitable for people with poor dentition, but can be crushed, or you can use the powder sachet. It's very small amount of absorbed, and this may deposit in liver and bone. But over so many years now, there's no toxicity, no drug interaction, blood levels remain very low, and the deposits go away after withdrawal of the drug. It shares biochemical properties with gadolinium, but does not cause nephrogenic systemic fibrosis. You may see insoluble complexes in GIT that are radio opaque on X-ray and CT, but there is no pathological significance, and and these images disappear upon withholding the drug for 1 or 2 days. It depends on the drug timing and dosing, and it's influenced by pre-existing diseases like diverticulosis. Iron-based binders, there are two: sucroferric oxyhydroxide, which is chewable or crushable and dissolves rapidly with high phosphorus binding capacity. No risk of iron overload because this form of iron is poorly absorbed, and it has much less pill burden compared to calcium-based binders and sevelamer, but again, may cause some GI upset. It may cause tooth staining, and it is costly. The other one is ferric citrate, which is equivalent to calcium-based and sevelamer. This form of iron, as you can see in the diagram, is absorbed. So it improves iron stores in hemoglobin, increases ferritin, and reduces ESA dose. However, you need to monitor the iron indices. It is expensive, and the citrate may increase aluminum absorption, as we mentioned earlier. Aluminum, we all know that it's highly effective, well tolerated, and cheap, but should not be used for more than a few weeks to correct severe hyperphosphatemia because of the long-term use effects on bone, brain, muscles, and causing dementia, myopathy, anemia, and osteomalacia. The serum aluminum levels are poor predictors of tissue aluminum level. Now, finally, the phosphorus absorption inhibitors, the gut binders, as you can see, tenapanor, it inhibits the passive paracellular transport of phosphate, currently approved for irritable bowel syndrome associated with constipation. And the phase 3 trial published last year showed its effectiveness in managing hyperphosphatemia. It is safe, effective, tolerable, with very low pill burden, but it can increase stool frequency. The other inhibitor is nicotinic acid, or its metabolite nicotinamide. It inhibits the active phosphorus transport. It is modest. Its effect is modest on phosphorus level, but can improve lipid profile. It's not recommended as single agent, used as combination. Can cause GI upset, and it can cause thrombocytopenia, so it's not recommended for patients with chronic liver disease. The last method of removal of or controlling hyperphosphatemia is dialysis. Well, unfortunately, conventional hemodialysis 3 times weekly, 4 hours per session, removes phosphorus inefficiently. Each session can remove good amount of phosphorus, less than 1,000 milligrams per session, but the total per week is less than 2,500 milligrams. High flux, high efficiency can improve the removal rate. Hemodiafiltration also can improve the removal rate. Increasing QB or QD do not. However, the best results that may even allow binder discontinuation are with increasing time. So short daily, extended daily, 3 times weekly nocturnal dialysis. PD, again, is an inefficient removal method for phosphorus. Depends on how many liters you use per exchange. So 2,200 milligram with 2 liters or 3,200 milligram with 3 liter exchanges. The removal is higher CAPD than automated in average and low transporters, but it's the same in high transporters. In patients in kidney replacement therapy, it's essential to attempt to preserve residual kidney function for as long as possible, control parathyroid hormone with cinacalcet, and avoid vitamin D to help control hyperphosphatemia. In conclusion, Hyperphosphatemia is at the core of CKD and MBD pathogenesis. It occurs late, but the adaptive mechanisms of hyperparathyroidism and high FGF23 occur earlier. Hyperphosphatemia is associated with increased cardiovascular mortality in CKD, and the control is first and central step in MBD management. However, there are no hard evidence that phosphorus control results in hard outcome clinical benefits. Dietary restriction is essential, but difficult and requires education. Phosphorus binders and lowering agents are unavoidable in the majority of patients. Calcium-based binders are of poor affinity and increased cardiovascular calcification. Sevelamer, the most widely used, but large pill burden. Lanthanum is more effective, lowers pill burden, but chewable. Iron-based therapies show promising features, and we are waiting for more data on the absorption inhibitor, tinapanor. Dialysis, unless of long duration or more frequent, is inefficient. With that, I conclude my talk, and I thank you all for listening.
I'd like to thank Professor Ahmed Khouria for his presentation about the diet in acute kidney injury and chronic kidney disease. And we have some questions to Professor Khouria from the audience. I think the first question is very simple and easy. Your comment, Dr. Ahmed, about low protein in dialysis, because I think it is, we don't like this style, low protein in hemodialysis. What's your opinion, Dr. Ahmed?
Assalamu alaikum wa rahmatullah. Thanks for the audience. Thanks for the conference organizers, Dr. Magdi Sharqawi. Thanks for the president and the chairperson of the session, وأخي الأستاذ دكتور حسين شعيشع. جزاكم الله خيرا جميعا. وبس I have to الحقيقة say comment إنه unfortunately
Professor Ahmed?
good في
Dr. Ahmed, you have problem in the net.
حسين
Yes.
انا سامعك كويس وانتم سامعاني كويس؟
No, there is interruption in your stream.
ايوه دكتور حسين انا سامعك كويس.
It's okay now, دكتور أحمد. Go ahead, please.
السيجنال عندي. ايوه السلام عليكم.
أيوه.
I will just يعني بشكر الاورجنايزرز والجمع والتشير بيرسونز واخي دكتور حسين شعيشه طبعا، وبس بكومنت على انه الحقيقه اخواننا في بيور سبوت قطعوا جزء مهم في نص البرزنتيشن في المونتاج في الترانزيشن من الاكيوت للكرونيك كيدني ديزيز، فسامحوني اذا كان في جزء في المسج ما وصلش. لكن بالنسبه
بروفيسور قريع excuse me دكتور أحمد. In the YouTube version, the presentation will be complete because in this session, it seemed that all lectures, all presentations, the time was not properly adjusted, and all speakers exceeded their time. Even Professor Sobh, Professor Iman. This is why they.
انا معاك بس هو القطع جه في حتت مهمه، يعني هم كانوا رجعوا لنا واحنا ما انتجناش نفسنا.
So let us go to the questions. Low protein in dialysis.
اللو بروتين ان dialysis طبعا is a crime. مفيش consensus على انه الهيموداياليسيس patient.
Excuse me, Professor Korea. دكتور أحمد. Please be in English because we have international candidates who don't speak Arabic. Yes, please.
Okay, so I was just saying that low protein in a hemodialysis patient is a crime. There is a consensus that a hemodialysis patient should receive 1.2 up to 1.4 gram per kilogram daily of protein, maybe of high biological value even, because they have excess protein loss on dialysis and the hypercatabolic state and so on. So there is no what's so-called the low protein diet on dialysis patient. Maybe an exceptional of this is the incremental hemodialysis patient, where the patient is not on regular hemodialysis yet because he has significant residual renal function. And there are some papers, especially in the Renal Nutrition Journal, about giving the patient high protein, including red meat and animal protein in the day of dialysis and the day just after the dialysis, and then go back to moderation of protein intake for the rest of the week till he had his next session.
Thank you very much,
I hope
Professor.
this answered the question.
Thank you very much, Professor Korea, for clarifying this point. This is why we asked you this question, because I discussed with Professor Khalid Abu Saif, and that this is a difficult question because it is basic to be generous in patients who are hypercatabolic in dialysis. But Professor Khalid said that some physicians neglected this issue and are not aware by this concept. This is why we asked you this question. We have some question to you from the audience about protein intake in nephrotic syndrome. Do you like to say one statement about this point?
Yes, the statement is protein intake in nephrotic syndrome it does not affect the progression of nephrotic syndrome as people usually thought. It is wise to increase protein intake to the average daily intake plus the amount lost in the urine. That's to say, if a patient is losing 10 grams of protein, you should give him on the average 0.8, maybe not 1, but 0.8 gram per kilogram body weight if he's 80 kilo. So give him 64 gram of protein, then add the 10 grams that he is losing. And this would suffice him to avoid the protein energy wasting.
I think this is the wisdom, because in the past, since many decades, there was a recommendation to give very high protein diet, and it is bad and not recommended by all of us. Thank you for this clarification. Regarding acute kidney injury, do you recommend high or low protein intake? This is one of the questions.
In acute kidney injury, you should give a protein intake according to the normalized protein catabolic rate or the nitrogen body appearance or protein appearance in the body, and you should calculate this as much as you can by energy expenditure if you can, and thus you would give high protein intake, not low protein intake, to counteract for the catabolic state, but it should be specific types of protein. And I'd like to highlight a point that was missed in the lecture, which is the difference between the amino acid that could be given in AKI and the keto analogs that are given in FAKI-D. There is total difference because some people are using this intervalably. They thought that ketostrel, for example, is like Nefrotect or Nefrostrel, and they are not. This is issue, and that's another issue totally. And this has its indication, and this had its indication. One part of, as well, of the part that was missing in the lecture is the amino acid supplementation with the branched chain IV form of amino acid in the AKI, which we recommend to use as long as within the premises of the allowed daily protein intake for the patient, especially if he is not taking enough oral or enteral feeding.
So your message is to individualize our approach according to our patients. If we have acute kidney injury with burn, for example, or severe sepsis and hypercatabolism, we shouldn't restrict protein in this context.
Yes,
okay.
Definitely.
The last question to you, Professor Correa, from the audience. Trace elements, fats, or vitamin supplementation in acute kidney injury.
Well, this is another issue again. Patients with AKI are usually oliguric, and this might cause some retention of some of the trace elements and as well as some of the electrolytes. On the other hand, they do not take enough enteral or parenteral feeding in some of the settings. So if the patient, and again, we've mentioned that the balance between the route of feeding should always go to the enteral way of feeding. And if you're giving the patient enteral feeding and his gut is functional, usually you don't need to supplement with trace element because you would give enough diet which contains everything. But if you're not using enteral feeding and you resort to parenteral feeding, you might need, especially if the AKI persists for a longer time, and especially so if the patient is on CRRT or plasmapheresis or continuous dialytic modality, even intermittent hemodialysis. A lot of people miss to give the patient not only trace element but also the electrolytes. Calcium, phosphorus, magnesium, and potassium might be lost with prolonged and protracted dialytic therapy of any modality on those patients with CRRT, and they should be monitored and replaced. And Professor Subhat gave a very nice lecture about zinc and the deficiency in different situations of the renal patient.
Let me thank you and appreciate your efforts in this presentation. And I'd like to emphasize on the last point you mentioned in the meta-analysis for primary prevention of chronic kidney disease. I think we should advocate this message, even if the evidence is low, to all people in the community, in the population, to know how to eat and to be doing physical activity, because to prevent chronic kidney disease is better than to treat the patients. Thank you very much, Professor Correa, for your excellent presentation and your discussion. Thank you very much.
Thank you, Professor Hussein.
Professor Dr. Ayman, you have a question. He's asking about, does CRRT has any effect on phosphorus level?
Yes, CRRT is a continuous renal replacement therapy, and during these sessions, the phosphorus is removed by a very high amount. If you know that HDF remove about 1,000 milligram of phosphorus, this is the HDF for 4 hours. If you continue with the replacement for few days, this will cause even phosphorus decrease, hypophosphatemia, and need even replacement.
في سؤال عندي أول السؤال بتاعي. طيب دكتورة إيمان، كان في سؤال كنت عايز أعرف.
In English.
English.
What about the amount of phosphorus in different types of proteins, and why there is a difference between every type of protein in this aspect? Second question, which food or drink contains a very high amount of phosphorus? to be avoided in our patients?
Thank you, Professor Osama, for this question, because I think the lecture is already not complete, but it will be complete on YouTube, inshallah. We have two types of phosphorus already. We have organic phosphorus and inorganic phosphorus. Organic phosphorus already, which is present in plant and animal. The plant, the phosphorus in plant, the absorption for it about from 20 to 40% of the total phosphorus in the plant. So as we have 100 gram of beans, equal about 3 tablespoons. This contain only 100 milligram phosphorus, only 100 milligram phosphorus, and this 100 gram. The other is the animal protein, which is also organic phosphorus, about 60% absorbed from the animal protein. This is the example for meat, chicken, egg, so on. And from the animal also I have different types of animal protein containing different amount of phosphorus. When we discuss this, we have already phosphorus to protein ratio less than 12 milligram per gram. This means that every gram of protein containing less than 12 milligram of phosphorus. And this is certain type of protein like lamb, like beef, like chicken, like some types of fish. There is another protein, animal protein, containing higher phosphorus, more than 12 milligram per gram protein, and this is like some type of fishes like sardine, shrimps. There is cheese, this containing higher phosphorus, and also the egg yolk. So even this animal protein, but we have different bioavailability with different types of animal protein. And this is demonstrated well in what's called the phosphorus pyramid. The phosphorus pyramid, we stratify the food for low phosphorus, very high, or high phosphorus, and very high in the tip of the phosphorus pyramid. The very high phosphorus is the processed meat, the processed chicken, and already processed cheese. This is very high in phosphorus. Also, some soft drink like Coca-Cola have a very high phosphorus. This is already colored red in phosphorus pyramid, and advice for all patients to be removed from diet or avoided as much as they can. This is why? Because they contain what's called the inorganic phosphorus. Inorganic phosphorus has high bioavailability, and the absorption from it is 100%. 100%. This is all the food processed contain what's called phosphorus additive. Phosphorus additive used to make the cheese or the chicken better taste, better shape. So this will add phosphorus, and this phosphorus is completely absorbed, so this will cause higher phosphorus bioavailability and contain very high phosphorus. We advise the patient to take the egg white and not take the egg yolk, because egg yolk contain higher phosphorus. We advise the patient to take the normal beverages like orange juice, any juice, but avoided soft drink like Coca-Cola, like other phosphorylated drinks. Also, we advise the patient to take, don't take too much milk, take only half cup of milk, 100 gram only, or milli, and not, cannot take decrease milk to only half cup, and better if there is available almond milk or other milk we can use.
What about the availability of medication?
Dear Professor Ali Saw, thank you very much for your, Dr. Ali?
Yes, sir.
Thank you very much for your presence and your presentation, which is very comprehensive about phosphorus control. And we like your statement about plant. Even in hemodialysis patients, we should advocate our patients for a portion of the diet to be from plant, because this is a good way to reduce phosphorus and to increase fibers for these patients. And I think there is a very nice systematic review about the value of plant even in hemodialysis without any malnutrition. The point that I would like you to comment is the hidden sources of phosphorus in in added foods and some drugs. We should advocate for labeling even the drugs and the foods about phosphorus content. I'd like to hear from you about this point.
Thank you, sir. To control phosphorus through dietary restriction is extremely difficult and very demanding. You actually need dietitian involvement to avoid any mistakes that can cause malnutrition. So dietitian can go with the patient through the list of foods that are rich, as my colleague alluded to earlier, and can educate the patient on how to read food labels, which can sometimes be difficult or misleading. But the patients need to be educated on how to read food labels, how to distinguish between canned food, frozen food, fresh food, processed food, tuna versus sardines, all these things. And the medications is actually the job of the pharmacist and the physician to go over the medication list, because sometimes, I gave you just an example. There's a longer list of medications that have phosphate. So imagine a patient is already on 5 of these medications that give him 100 milligram per day of phosphorus, and now he's left with 700 milligram only to take from food. So we need to carefully look at the medications and their contents, review the medication chart regularly. Our patients have other comorbidities, so they may go and see other specialists. So we need to see if they have been prescribed any new medications and take it into consideration.
Thank you very much, Professor Ali. We learned from your presentation that we should target the triad: diet, drug, and dialysis. This is why we shouldn't neglect the adequacy of dialysis for our patients to help. So diet, drugs, and dialysis. Dr. Haber?
Thank you, Dr. Ali, for this comprehensive lecture. You told us about management of hyperphosphatemia, starting from diet, dialysis, phosphate binders, and also you told us about inhibitors of phosphorus absorption. We want to clarify point of applicability, availability, and how to use. Is it available about phosphorus absorption inhibitor? We don't have this experience in our country, so if you can advise us about what about applicability, availability, and if there is any concern about this.
Okay, thank you, sir. This is a very important point. There are right now 2 kinds of phosphate absorption inhibitors that I talked about briefly. The one we already have, nicotinic acid or niacin, is weak, cannot be used alone, and it may not be good for people with the liver disease or thrombocytopenia, and we have patients with heparin, so it may not be widely used, and it's actually not widely used. The other one, tenapanor, has not been officially approved. So yes, it's not available worldwide, has not been officially approved for management of hyperphosphatemia. There was a successful phase 3 trial published late last year, showing the safety and efficacy and tolerability with excellent low bilirubin. We're talking about 2 or 3 maximum per day, which is going to be amazing for most of our patients. But it has not been approved for hyperphosphatemia, approved for management of irritable bowel syndrome associated with constipation. But hopefully, I think the company is probably going to contact FDA to start the process, which is going to take at least a year. So hopefully next year we will know more about that.
Okay,
Thank you very much,
you.
Professor Ali. I would like to thank all speakers, starting from Professor Ahmed Kureya, Professor Iman Sarhan, Professor Sobh, and lastly, and not least, Professor Ali Saw. It was a very fruitful session, and I enjoyed the discussion. Thank you very much, and we'll go directly to the next session.